Good morning, all. Today's lecture is about oral habits. These are the content which we are going to cover in part A and part B, which includes introduction, definition, classification, common oral habits in children, that is thumb sucking habits, tongue thrusting habits, and mouth breathing habit. Other habits which includes bruxism, lip biting, pillowing habits, frenum thrusting, bobby pin opening. Now we start with an introduction. A wide variety of oral habits occur in the infant and young children has been in the center of much controversies for many years. Orthodontists, parents, pediatricians, psychologists, speech pathologists, and dentists have discussed and argued the significance of oral habit, each from view of point of their specialty. Now we start with definition. Habits are quoted by Hugman and attributed by Selder. It is the most methodical way in which mind and body acts due to an frequent repetition of a certain definite sets of nervous impulses. As constant settled practice or custom established by repetition of a same act. A repeated static or functional exercise is defined as a habit. A habit may be defined as a tendency towards an act that has become a repeated performance, relatively fixed, consistent, and easy to perform by an individual. And Williams James, and he was an ancient psychologist, defined habits from psychological point. He says, as habit is nothing but new pathway of discharge formed in a brain by which certain incoming currents then tends to escape. Now we'll start with the classification. According to Sigmund and Finn, there are two type of habits, which is first is compulsive and second is non-compulsive. So we'll start with non-compulsive habit. What are non-compulsive habits? They are the habits that are easily learned and dropped as a child mature. The compulsive habits, as you can see in the picture, the patient is mature and still he or she is going through some habits. It is compulsive habits. These are the deep-rooted habits that have acquired a fixation in the child to the extent that the child retreats to the habit whenever his security is threatened by any event which occurs around him or her. The child tends to suffer increased anxiety when attempts are made to correct the habit. The other way is the primary and the secondary habit. The primary, it is the first habit that is acquired, which, for example, it says thumb sucking habit. Now, secondary is the habit that accompanying the primary habit, for example, tongue thrusting habit, along with the thumb sucking habit. This is known as the secondary habit. Now, by Klein's classification, we have two type of habits, that is intentional habits and it is unintentional habits. Intentional habits says it functions as an important psychological property for the child. For example, thumb sucking habit. Unintentional habit, that is presumed even though the child does not support, that is mouth breathing habit. It means patient doesn't want, the child doesn't want, but due to some reason he had to or she had to breathe from his mouth. Brush classification, individual habit, for example, lip sucking habits, habits in which there is combined action of muscles of mouth and jaws with the thumb and finger insertion. Muscular actions and introduction of passive objects into mouth, for example, pacifiers. Habits in which muscles of the mouth and jaw takes no active part. The effect on position of dentition being extraneous. For example, pillowing habits. Functional disturbances, that is mouth breathing. Now, functional classification is functional oral habits, for example, mouth breathing, muscular oral habits, which includes lip and cheek biting, combinations of oral muscular actions and other ways, that is thumb sucking, and postural habit, that is chin prompting habits. The fifth is Anderson classification, which was given by Anderson in 1963. He said we have two type of two type of habits, that is pressure habits and non-pressure habits. Pressure habits includes the sucking habits such as thumb sucking, lip sucking, finger sucking, and also tongue thrusting. On non-pressure habits, that's habits which do not apply a direct force on the teeth or its supporting structure, that is mouth breathing habits. Normal, for example, nutritive sucking. Abnormal, which includes tongue thrusting or thumb sucking habit. Psychological, which is nutritive sucking habits. Pathological, that is mouth breathing. Functional habits, we have mouth breathing habits. Non-functional, that is tongue thrusting habits. Useful and harmful habits. Useful habits should include all those habits of normal function, such as correct tongue position, proper respiration, and deglutination, and normal use of lip in speaking, and etc. Which these includes useful habits. Harmful habits, which includes all that exerts prescribed stress against the teeth and dental arches, as well as those habits such as mouth breathing, lip biting, lip sucking, etc. These are harmful habits which actually exert pressure and deform the occlusion of the patient. Meaningful habits and empty habits. Meaningful habits includes is a habit with a psychological problem deep rooted and must be treated accordingly. Empty habits is a meaningless habit and can be treated easily by the dentist with parents' help using a habit reminder appliances. Now, the next slides goes for common oral habits in children's, which includes thumb sucking habits, which is very important for an orthodontist, tongue thrusting habits, mouth breathing habits, bruxism, nail biting, finger biting, tongue sucking, self mutilations. Now, sucking habits. Sucking habits is a reflex occurring in oral stage development and disappears during a normal growth between the age of 1 to 3.5. It is the first coordinate muscular activity of the infant, which says if the child is less than 3 years and patient and the child is going through thumb sucking or finger sucking or digit sucking habits, seems to be normal because of the oral stage development. And when the child develops after 1 to 3.5 years, slowly the digit sucking habits vanishes. If suppose it doesn't vanish, now the direction of the habit is going through severe thumb sucking habit for the patient. Now, sucking habits can be classified into nutritive and non-nutritive. Nutritive sucking habits which provide essential nutrition to the infant, for example, breastfeeding and bottle feeding. Non-nutritive sucking habits, it is the habit adopted by infants in response to frustration and to satisfy their urge and need for contact, for example, thumb sucking habit, finger sucking habit, and pacifier sucking. Now, thumb sucking or digit sucking habits. Now, as you can see, uh, in the picture, the patient has put his thumb inside his mouth while sleeping. It is defined as a placement of thumb or one or more fingers in varying depth into the mouth. Now, the classification of thumb sucking habit is group 1. That the group 1 says the thumb plays into the mouth beyond the first joint and of the thumb and occupies a large portion of the vault of the hard palate, pressing against the palate and alveolar mucosa. As we can see in the image, the thumb is placed deep into the palate. Now, the group 2 says the thumb did not go completely into the vault area of the hard palate. However, it usually enters into the mouth up to and around the first joint or just anterior to it. As we can see the same thing in this image. Now, group 3 says the thumb, the group 3 says the thumb passes fully into the hard palate as in group 1. Now, group 4 says the thumb did not progress appreciably into the mouth. The lower incisors made contacts at the proximate level of the thumbnail. See the image. It is clearly seen the thumb is touching and the lower or at the lower incisors. Now we'll see the etiology. Etiology says a number of theories have been put forward to explain why thumb sucking occurs. The Freudian theory, the theory has proposed by Sigmund Freud. He suggested that the child passes through various distinct phases of psychological development, of which the oral and the anal phase are seen in the first 3 years of the life. In the oral phase, the mouth is believed to be an oroerotic zone. The child has the tendency to place his finger or her finger or any other objects into the oral cavity. Prevention of such an act is believed to result in emotional insecurity and poses the risk of child indulging into other habits. Now, oral drive theory by Shear and Weiss proposed that prolonged sucking can lead to thumb sucking with no underlying cause or psychological bearing. Benjamin theory says that he suggested that thumb sucking arises from the rooting reflex seen in all mammalian infants. Rooting reflex is the movement of the infant's head and tongue towards an object touching his cheek. The object is usually the mother's breast, but may also be a finger or a pacifier. This rooting reflex disappears in normal infants around 7 to 8 months of the age. The psychological aspect says that children deprived of parental love, care, and affection can believe to resort to this habit due to the feeling of insecurity. Now, learned pattern. The behavioral theory state that the digit sucking is merely a learned pattern of behavior with no underlying cause and no more emotional or psychological problem than are found among non-digit suckers. Advocates of this theory suggest that digit sucking may even increase anxiety. Thus, if a habit is eliminated, there need to be no other habits begin as substitute. It means the pattern should be changed. If one habit is treated, we have to stop the other habit also. Dentofacial changes associated with prolonged NNS habits. Effects on maxilla: increased proclination of incisors, increased maxillary arch length, increased anterior placement of apical base of maxilla, increased SNA, increase clinical crown length of incisors, increase counterclockwise rotation of occlusion, decrease palatal arch width, increase apical root resorption of the primary central incisor, increase trauma to the central incisors. Effect on the mandible: it increases the proclination of incisors, mostly we say retroclination of incisors, increase intramolar distance, increase distal position of point B. Effect on interarch relationship: decrease maxillary and mandibular incisor angle, and increased overjet, decreased overbite, increase posterior crossbite, increase unilateral and bilateral class 2 occlusions. Effect on lip placement and functions: increase lip incompetency, increase lower lip function under maxillary incisors. Effect on tongue placement and function: it increases the tongue thrust, increase lower tongue position. Other effects: it increases the deformation of digits, increase risk of speech defect, especially lisping. Now, the diagnosis: how we diagnose the habits. The diagnosis of thumb sucking consists of four diagnostic procedures. First is history of digit sucking. Information on whether the child has had an history of digit sucking obtained by parents. When there is a positive answer, one should ask the question how frequently and how long it lasted and its intensity and what remedies have been tried at home to stop all the thumb sucking habit to the patients. Second is emotional status. The child's emotional status should be assessed by asking questions like feeding habits, parental care of child, whether the parents are working or not. It's a very important question for nowadays because most of the parents, the mother and the dad and the father of the pay of this patient, they both work and they don't have time due to corporate jobs and all. They are not able to give proper time to their children. So as an insecurity, the child started thumb sucking habits. Extra oral examination, the dentist should check the parent's digits, the patient digits. They should be compared with the opposite finger of the other hand. The finger engaged sucking with often appears reddened or exceptionally cleaned, chapped with a short fingernail thumb. Due to the constant sucking of the thumb or the finger may have thick callus formed. Now we start with extra oral examination. Now we start with intraoral examination. A good intraoral examination should be a key to diagnosis of the habit with its clear picture of clinical feature. These features are flared maxillary anteriors with diastema, high probability of buccal crossbite, narrow maxillary arch, lingual tipping of the mandibular incisors, and open bite. Now, the management may be divided into preventive, interceptive, corrective, and corrective have subtypes, that is early treatment and late treatment, and the post treatment retention. The treatment procedure could be introduced during three phases of development of dentition. Preventive, primary dentition between 3 to 5 years. Interceptive, eruption of permanent incisors in progress, that is 6 to 8 years. And corrective, eruption of maxillary molars in progress, 8 years up to eruption of all permanent teeth. And the late corrective treatment is, which includes the treatment in adults. Now, the beta hypothesis method of correction is known as Dunlop hypothesis. This theory holds that practicing bad habits with an intent to stop it will learn not to perform that undesirable act. However, the child must know that the intention is having him or her in a practice, the habit is to break him off the habits. Furthermore, the child is not being allowed to fall onto daydreaming or derive satisfaction from purposeful repetition of the habit. This is practiced only in older children's cooperation can be obtained. Cooperation is very important in this hypothesis. Now, mechanical treatment. Mechanical restraints applied to the hand or digits like splints held by adhesive or two holes drilled into strings in the wrist. Adhesive bandages applied on the digit. Now, Levin described a method of altering the little clothing, pajamas, so that the hand cannot be moved from the mouth to the mouth. Daily records kept by the child to use the telephone to report how many times he or she had sucked his thumb. Later, if the frequency of the sucking reduces, the call can be spaced apart. Its self-help program is not successful. The child asks for the help of the dentist and an intraoral appliance or any other techniques advocated by the dentist can be employed. Now, thumb guard, it is a soft acrylic covering around the thumb worn at night. Fabricated by the dentist, made of soft acrylic, has holes to approximately 3 by 16 inch in diameter drilled into it to break the sucking seal. It is tied to the wrist at night to avoid thumb sucking habit for the patient. So as you can see, these are some images which we can see different methods have been used to help stop the child to advance or to make thumb sucking habit even good. And the fourth image, you can see the clean thumb and a small tissue growth over here which shows the patient use this particular thumb in thumb sucking habit.